wanna know. Okie dokie. Alana. Okay. Testing, testing. 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 Okay. Chapter 15, 354, mechanical ventilation. This is troubleshooting. Troubleshooting in the context of mechanical ventilation involves the identification of technical malfunctions in patient ventilation. Troubleshooting can be thought of as purposeful resolution of inappropriate and potentially dangerous situations. To review key concepts used in the management of patients receiving mechanical ventilation. Common technical problems encountered during mechanical ventilation presents basic problem-solving strategic strategies to ensure patient safety. The term problem defined as a situation in which a person finds discord or a matter that cannot be immediately resolved. Increasingly, a situation might be uncomfortable for one person to be a problem for another person. The therapist in the intensive care unit will alarm be activated for the intravenous pump. The person's job function might not perceive this as a problem. Resolved and they simply contact the nurse. In contrast, if a ventilator alarm is activated, the same respiratory therapist will accept responsibility going to the patient's bedside to assess the situation and finding a solution to the problem. Individuals therefore must perceive an event as a problem by a meaningful solution. The other situation must create discomfort, which forces someone perceiving it to the actual ability to find a problem is particularly important to healthcare practitioners. Patients receiving ventilatory support may ultimately depend on mechanical ventilators, and a matter of minutes can mean life or death because potential mishaps can occur with the patient. But it's essential that clinicians develop the ability to identify and correct associated problems. Solving ventilation problems. The first step in solving any problem is to assess the situation carefully. Is to gather pertinent data which should point to a number of viable solutions. When a solution is attempted, the clinician's observations of the patient's response are critical. This positive remedy, the problem is resolved. The clinician must undo what was attempted and try to determine the reason the particular solution failed. Another approach. The clinician should seek help. Cannot be resolved, the clinician should seek help. So the problem can help prevent its recurrence. In box 18-1, solve the problem shown in figure 8. Which individual or individuals first perceived it as a problem? What steps were taken to determine the cause? The volume delivered by the ventilator, the inspiratory portion of the volume curve, and the volume extended. Possibly because the patient is actively exhaling. A patient evaluation reveals that this is not the case. Respiratory therapist unable to explain the cause with the respirometer to measure the volume coming from the volume delivery port, the patient and the exhalation valve are equal. Still unable to determine respiratory therapist contacts performs the maintenance. The respiratory therapist learns that the expiratory transducer is for a heated humidifier. However, a heat and moisture exchanger is being used with this patient. Separating the transducer will resolve the issue. Depending situation, actions required. Protecting the patient. It is important to understand that ensuring the patient's safety is the foremost obligation of the clinician. Activates on a ventilator or monitored device should make sure the patient is adequately oxygenated. This can be accomplished by visually accessible consciousness, use of X and chest wall movements. The initial assessment check and size. Auscultation of the chest can establish the presence of adequate and checking the SpO2 about the patient heart rate. The patient is in acute stress or labor. Okay, troubleshooting. Okay, troubleshooting a problem using ventilator graphics, box 18-1. The intensive care unit at pulmonologist just noticed a ventilate showing the expiratory portion of the volume curve dropping below baseline. 18-1. The therapist inquires about possible causes. Figure 18-1. Curve A shows a normal volume time curve. Curve B shows the expiratory portion of the volume below the zero baseline. Okay, page 355. It says the patient is in acute distress with labored breathing, apheresis, and apparent anxiety, along with deterioration of breath sounds and a decreasing SpO2. Immediate actions required. When a serious problem is detected, the patient may need to be disconnected from the ventilator and manually ventilated with a resuscitation bag. When the patient is safe and in stable condition, the clinicians can review the cause of the alarm activation and obtain help from other personnel if necessary. A resuscitation bag can be used temporarily for ventilation in the patient. When it is used properly, the resuscitation bag allows for the assessment of lung characteristics, because clinician can check, feel a patient's lung and chest wall compliance and airway resistance. Manual ventilation must be performed cautiously to avoid inappropriate patterns of ventilation, excessive pressures, for example, greater than 40 centimeters H2O, and barotrauma. Additionally, ventilator disconnection of a patient with ARDS who is ventilated with a high level of P, 15 to 25 centimeters of water, can cause decruitment of the lungs, derecruitment of the lung, resulting in desaturation. Manual ventilation must also be used judiciously, because disconnecting the patient from the ventilator can also result in contamination of the patient's airway, which in turn can increase the patient's risk of developing ventilator-associated pneumonia. Identifying the patient in sudden stress. The term patient ventilator asynchronous typically used to describe phenomena that occurs when patients are unable to breathe comfortably with a mechanical ventilator. The phrase "fighting the ventilator" is sometimes used to describe an individual who is apparently doing well while receiving mechanical ventilation but suddenly develops acute respiratory distress. Particularly challenging for most clinicians because the patient is unable to verbalize his or her discomfort. Sometimes clinicians can gain valuable information from patients simply by asking direct yes or no questions. Key 8.18-1. Problem we created cannot be solved with the same level of thinking that we have when we created. Okay. Sudden onset of dyspnea can be identified by observing the physical signs of distress. Figure 18.2, including tachypnea, nasal flaring, diaphoresis, excessive muscle use, retraction of the suprasternal, supraclavicular, and intercostal spaces. Paradoxical or abnormal movement of the thorax and abdomen, abnormal findings of auscultation, tachycardia, arrhythmias, and hypotension. Pulse oximetry, capnograph readings, ventilator graphics, peak inspiratory pressure or PIP, plateau pressure or P plateau, and exhale volumes may have changed and may provide information to help identify the cause of the problem. Ventilator asynchrony or dysynchrony can be caused by a number of factors. Box 18.2 lists the most common causes: sudden respiratory distress in patients receiving mechanical ventilation. See the section in Chapter 17 on steps to reduce the work of breathing, WOB, during mechanical ventilation. Evaluation of the ventilator graphics and settings can be used to resolve most of the problems. For example, auto-triggering of breaths can occur if the sensitivity setting, respiratory trigger is okay. Let's go over these figures really quick before we go to the next page. 15.2 says physical signs of severe respiratory distress. It has clinical manifestations: use of accessory muscles to breathe, pursed lip breathing, minimal or absent cough, leaning forward to breathe, barrel chest, digital clubbing, or dyspnea on exertion. Late sign. Causes of sudden respiratory distress in patients receiving mechanical ventilation. Artificial airway problems, bronchospasms, secretions, pulmonary edema, pulmonary embolus, dynamic hyperinflation, abnormal respiratory drive, alteration in body posture, drug-induced problems, abnormal distension, anxiety, ventilator-related causes, circuit malfunction or disconnection, inadequate F2O2, patient ventilator asynchrony, which then is the following list: inappropriate ventilator support mode, inappropriate trigger sensitivity, inappropriate inspiratory flow setting, inappropriate cycle variable, inappropriate peak setting, problems with closed loop ventilation. Okay, let's see. Value, going to the next page. Evaluation of ventilator graphics and setting can be used. For example, power triggering as effects can occur if the sensitivity setting or respiratory trigger is top sensitive. In an excessive number of triggered breaths. Patient ventilator asynchrony is often associated with the patient's feelings of pain, which can be relieved by encouraging the patient to not fight the ventilator and relax while breathing with the ventilator. Selection of the appropriate mode, a correct adjustment of the ventilator can limit most problems and reduce the need for sedation. See Chapter 17 for more detailed information on patient ventilator asynchrony. Identifying the cause of patient ventilator asynchrony can be accomplished using a relatively simple approach. Fox 1830. If the patient is used, if the patient is in severe distress, first step is to disconnect the patient from the ventilator. Carefully ventilate the patient using a manual resuscitation bag, i.e., avoiding excessive airway pressure. And I know why. The stress evolves immediately. The problem is the stress cannot the stress cannot solve the problem is typically due to patient experiencing anxiety or pain. Key point 18.2. In cases where patient ventilator asynchrony is identified, clinicians should disconnect the patient from the ventilator and carefully ventilate the patient uh, using a manual resuscitation bag. Patient-related problems. The most common patient-related problems encountered during mechanical ventilation involve the problem efficacy of the artificial airway and or the precursor. Let's see. Airway problem. Okay, next section, patient-related problems. The most common patient-related problems encountered in mechanical ventilation involve placement and patency of the artificial airway or the presence of pneumothorax, bronchospasm, and excessive secretion. See 18, box 18-2. Airway problems. Examples of acute airway problems include thinking of the endotracheal tube, impingement of the tube of the carina, and displacement of the tube upwards above the vocal cords or into the right. Airway problems. Examples of acute airway problems include emptying of the endotracheal tube or ET, impingement of the tube on the carina, and displacement of the tube upward above the vocal cord or into the right mainstream bronchus. Box 18.4. Rupture of the innominate artery can also occur. This is usually seen with the tracheostomy tube. Box 18.5. An unusual case study reported a fatal tracheal innominate artery fistula caused by fixed positioning of the hyaloevac to the upper molar. This type of ET is for the continuous aspiration of the sublateral secretions leading to sexual frustration. Soft tissue of the trachea for an extended period resulted in erosion of the tissue, eventually exposure of the innominate artery. This catheter has been redesigned to reduce the risk of this complication. A quick check at the patient's oral cavity could sometimes reveal whether the ET is kinked or the patient is biting it. The clinician can easily determine whether the tooth is being inserted too far or if it shows in the airway by looking at the tube at the airway opening. A properly positioned oral ET typically shows the scenario, marking at the teeth at approximately 23 centimeters for men, range 22 to 24 centimeters, and 21 centimeters for women, range 20. If the centimeter markings are less than the range of sight of the tube is too high in the airway. If the marking is greater than the range of sight of the tube has migrated deeper into the airway. If a serious airway problem cannot be resolved quickly, the clinician should ventilate the patient manually to assess airway patency. If the patient cannot be ventilated in this manner, appropriately end-sized suction catheters should be passed through the artificial airway. The catheter does not pass freely and the patient is not fighting on the ET. The tube is most likely obstructed. Cuff should then be deflated, which may allow some of the air to move around the tube and spontaneously leaving the patient. The obstruction cannot be cleared. The tube must be removed immediately and the patient ventilated with a resuscitation bag as a mitigation. Okay. Page 257. Next. Oh, wait. Go for these. Box 18.3 Management of sudden severe respiratory distress in chemical ventilated patient. This is on page 256. Disconnect the patient from the ventilator. 2. Begin manual ventilation using a self-inflating resuscitation bag containing 80% and 100% oxygen, maintaining normal ventilation. Go to this again. 18. Box 18.3, the ventilator, bed manual ventilation using a self-inflating resuscitation bag containing 80% to 100% oxygen. Maintain normal ventilating pressures and use a PEEP attachment if the patient has been on high PEEP, which is greater than or equal to 10 centimeters of water. Manually evaluate compliance and resistance through bag ventilation. Perform a rapid physical examination and assess monitored indexes and alarm. Check the patency of the airway by passing a suction catheter. If death appears imminent, consider and treat the most likely problem: pneumothorax and airway obstruction. Okay, now box 18.4, causes of airway problems that can lead to sudden respiratory distress. Tube migration, flexion, an extension of the head and neck can move the endotracheal tube (ET) in the airway, an average of 2 centimeters down and up respectively. Maybe negation that. Migration of the ET above the vocal cords. Migration of the ET into the right mainstream bronchus. Rupture or leakage of the ET cuff. Kinking of the ET. Patient biting the ET. Airway secretions and mucus plugging of airways. Impingement of the ETs on the carina or airways. Cuff herniation over the head of the ET. Less of the problems with the planet individuals. Or development of the about that, and finish these bullets in 18 for rupture linkage of the ET cuff, fourth bullet, kinking of the ET, patient finding airway secretions, and mucus pluggings of airways, impingement of the ET on a carina or airway, cuff herniation over the end of the ET. That's the problem with the current endotracheal cuffs, and development of tracheoesophageal fistula, and rupture of the innominate artery. Emergency treatments for rupture of the innominate artery. Rupture of the innominate artery is potentially serious airway complication, and the mortality rate of this condition is high. It is usually seen in the first 3 weeks of tracheostomy. The immediate indication is blood spurting from the trachea during study. To stop the hemorrhage, the cuff should be overinflated, or pressure should be applied internally with a finger inserted through the stoma. The finger is inserted as far as possible toward the carina and then pulled forward in an attempt to compress the artery against the posterior aspect of the sternum. Now, page 357, pneumothorax. This is another possible problem that must be detected during positive pressure ventilation (PPV) and treated quickly. Pneumothorax can be recognized as increased WOB if the patient is cautious. For example, the patient may have nasopharyngeal, use of accessory muscles, uneven chest wall movement, and absence of breath sounds on the affected side. Auscultation and percussion of the vest. Cardiovascular assessment and ventilating pressure evaluations usually can distinguish a pneumothorax from other problems. Table 8.1 provides physical and radiological findings, commonly seen in patients with pulmonary disorders such as pneumothorax, asthma, emphysema, pneumonia, and pleural effusion. If a tension pneumothorax is strongly suspected and cardiopulmonary arrest is imminent, a 14 or 16 gauge needle is inserted into the Second intercostal space at the midclavicular line over the top of the rib on the affected side. If the patient's condition is stable, a confirming chest radiograph can be obtained with chest to placement and pleural range. Following case study describes the case of a patient with sudden respiratory distress. Clinical scenario: a case of respiratory distress. Clinical scenario: a case of sudden respiratory distress. A 45-year-old woman has been receiving ventilation for 3 weeks arising from severe asthma. Treatment has included administration of sedatives, antidepressants, and corticosteroids, as well as bronchodilator therapy. Several attempts of weaning, including a course of non-invasive positive pressure ventilation or NRV, have been unsuccessful. 36 hours after successful placement of a tracheostomy tube, the patient's ventilator high pressure alarm activates. The respiratory therapist performs an assessment and suctions the patient's airway, which is determined to be bad. Both sounds are diminished, but present bilaterally. Within 10 minutes, high pressure alarm activates again. Respiratory therapist returns to the room and notes that the patient appears to be coughing coarsely. Says 36 hours after successful placement of tracheostomy tube, the patient ventilator high pressure alarm activates. The respiratory therapist performs an assessment and suctions the patient's airway, which is determined to be patent. Breath sounds are diminished but present bilaterally. Within 10 minutes, the high pressure alarm activates again. The respiratory therapist returns to the room and notes that the patient appears to be coughing hoarsely. The patient suddenly develops ventricular tachycardia and loses consciousness. The respiratory therapist finds it extremely difficult to ventilate with the tracheostomy tube. The tube is pulled and the patient is immediately and successfully reintubated with an oral ET. Unfortunately, resuscitation efforts fail, and a postmortem chest radiograph shows bilateral pneumothorax. Clinicians conclude that thickened secretions have blocked the airways, causing air trapping distally, and that increased pressures in the thorax for the patients cause the bilateral pneumothorax. And we're on to bronchospasm. Spasm may be manifested as dyspnea, wheezing, and evidence of increased WOB, i.e., such as heightened use of accessory muscles, lack of coordination of chest or abdominal wall movement, retraction of the suprasternal, supraclavicular, and intercostal space, and increased raw as evidenced by increased PRP, and trans airway pressure, PIP minus peak plateau, reason associated with the increased draw from airway hyperactivity such as occurs with asthma, can be treated with bronchodilators and parenteral corticosteroids. Music can also be associated with cardiogenic problems and pulmonary emboli. Secretions. Evaluation of the patient's secretions can be useful to differentiate a variety of problems. See Table 12.2 for a list of study findings and possible associated problems. Drying of secretions is most often associated with inadequate humidification. Key point 18-30. Copious amounts of secretion can occur with pulmonary edema and certain pulmonary disorders like cystic fibrosis. Depending on their characteristics, secretions may also suggest the presence of respiratory infection. However, this is not usually a problem with sudden onset. It's essential that the patient is provided appropriately warmed and humidified air. Suctioning should be performed only when indicated rather than according to a fixed schedule. Bronchial hygiene may include postural drainage and percussion and therapeutic bronchoscopy. Chapter 12 presents additional information on bronchial hygiene and therapeutic bronchoscopy. Patients is most often associated with inadequate humidification. Pulmonary edema. Pulmonary edema can be either cardiogenic or non-cardiogenic in origin, and should be managed accordingly. Cardiogenic pulmonary edema can occur suddenly and often manifests with thin, frothy, white secretion. This where cardiogenic pulmonary edema is suspected, the clinician should check for additional evidence of cardiac problems such as electrocardiographic findings, elevated blood pressure, evidence of neck vein distension, a history of heart disease, and data from a pulmonary artery catheter, if available. See Chapter 11. Cardiogenic pulmonary edema and heart failure can often be managed successfully with medications that reduce preload, increase contractility, and reduce afterload, such as furosemide, Lasix, digoxin, Lanoxin, and alacromelia, or Basotec, and morphine. Non-cardiogenic pulmonary edema or pulmonary edema that is caused by an increase in pulmonary capillary permeability, e.g. ARDS, usually develops over a day or two and is not a sudden onset problem. The management of ARDS is discussed in chapters 13. Inflation also causes burning and hyperinflation of the lungs. It can lead to difficulty in ventilating and ventilator fatigue. Auto-PEEP can also cause cardiovascular problems such as hypotension and reduced cardiac output. One of the best ways to detect the presence of auto-PEEP is through the evaluation of the ventilator waveforms. Auto-PEEP should be suspected whenever flow does not return to baseline in either a flow timescale, see figure 1711, or a flow volume lead, see figure 1041. Efforts to reduce auto-PEEP can be aided by reducing the inspiratory flow by reducing the inspiratory time, T1, to minute ventilation, V2, and Raw. Chapter 17 provides additional information on autopsy. If autopsy hinders a patient's ability to trigger the ventilator, see Figure 7.1. See Chapter 7.4 discussion on how raising the applied P, extrinsic P, can be used to ease breath triggering in patients with chronic obstructive pulmonary disease, or COPD, when autopsy cannot be completely eliminated. Abnormalities in respiratory drive. Inadequate output from the respiratory centers of the brain can occur as a result of heavy sedation, acute neurological disorders, or neuromuscular blockage. However, these conditions are more likely to reduce respiratory function than to produce the sudden respiratory distress. Decreased output from the respiratory centers is associated with the pain, anxiety, and increased peripheral sensory receptor stimulation. Medication. Increased respiratory needs and inappropriate ventilator setting. Change in body position. Changes in the patient's body position can be associated with accidental extubation, bending and twisting of the patient's circuit, and in some cases, alteration in the patient's overall oxygenation. Reductions in oxygenation can occur when repositioning the patient. The position of the patient so that the diseased lung is placed in a dependent motion position can also occur with some airway obstruction within mucus plug secretions or a clot migration that leads to a pulmonary embolus. Changing the patient's body position can cause a thrombus to dislodge and migrate, causing a pulmonary embolus. Distress. Recognize that when acute respiratory distress develops in a ventilated patient in the ICU and the cause cannot be readily identified, possible causes may be related to medications the patient takes or possibly chemical dependency. For example, intravenous morphine, which is commonly used to relieve pain, can cause nausea, hypotension, disorientation, hallucinations, fever, constipation, and respiratory arrest. This may be especially true in older patients whose ability to metabolize and clean medication may be diminished. Patients with chemical dependency, alcohol, drug, or tobacco, present additional clinical management issues, particularly if the ICU staff is unaware if the patient's chemical dependency. Sudden interruption of the use of the chemical medication may cause symptoms of withdrawal syndrome, such as anxiety, restlessness, irritability, insomnia, and inability to focus attention. Abdominal distension. Abdominal distension can be associated with the air being introduced into the stomach via a nasogastric tube, and with a number of disorders, including ascites, abdominal obstruction, and liver or kidney disorders. Some of these conditions have a slower onset than others, but all cause an upward pressure on the diaphragm. Its downward movement. Diaphragm movements can lead to atelectasis, the vascular lungs, ventilation, perforation abnormalities. Hello. Hey, I'm at my mother's house. Yeah. No, no, no. I'm cool. I can just hold on 1 second. Let me put this on pause. Okay. I will start with pulmonary embolism section. Okay, and pulmonary embolism PE is another accurate onset problem that ventilator is sinking. The rapid onset of hypoxemia from a large embolus leads to all the signs of distress like the patient typically demonstrates bilateral breath or sounds, indicating that both lungs are being ventilated, i.e. PE interferes with diffusion and ventilation. With PE heart rate, blood pressure, and respiratory rate, even with higher ventilator rates, and both patients may use accessory muscles to breathe and may become very pale. Checking airway dependency and ventilator pressures and increasing F2O2 may not reverse arterial oxygenation. Spot. Not reverse arterial oxygen desaturation, SaO2. Disconnection from the ventilator and manual ventilation will also not relieve the distress. Pulmonary embolism often leads to helpless to determine the cause of the Capnography findings can, however, provide a decrease in carbon dioxide to value compared with the previous readings of arterial to the end titled partial pressure CO2 gradient. The presence of an embolus. The presence of a PE usually requires a angiogram and computerized the thrombolytic therapy, such as the antiplase, recombinant tissue class, is recombinant TPA activist, retivase may be inappropriate. Clinicians typically rely on algorithms to identify problems. Ventilator-related problems. Ventilator-related problems. Clinicians relate algorithms to identify problems with the patient ventilator circuit. Way to identify whether the problem is ventilator-related is to determine whether respiratory stress is relieved by manual ventilation and oxygen. If sees respiratory prevention relieves the respiratory stress, then the problem is probably associated with the ventilator, like ventilator management strategy. Study evaluating severe respiratory distress in the ventilated patient. Patient ventilator check. The respiratory therapist notes that the patient of respiratory distress, saturation alarm, oximeter activates, breath sounds are equal bilaterally with no change from previous findings. The respiratory therapist disconnects the patient and performs manual ventilation using 100 oxygen. A suction catheter passes through the patient's ET without difficulty. Patient's distress continues and oxygen remains low. Note the capnometer reading PETCO2 has changed from the previous value meters HD to 2 meters HD. Analysis is that the DOCO has not voted to decrease the MMPA-ET increased from 6 millimeters HD to 14 millimeters HD. Other patients' respiratory distress. Okay, I'm going to take a break and get back again at least on 359. Okay. Testing, 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 test two, three. Okay. Chapter 18. Uh, for chapter 6. Have to just change it. This is chapter 18, page 359. Pressure, low volume, and B1 in the patient ventilator circuit is present. In this chapter, the presence of a leak can be verified by analyzing various ventilator graphics are available on most ICU ventilators. Leaks are commonly caused by the ventilator. Ventilator circuit simply needs to be connected to the patient's artificial airway. Leaks and help with determining this clinicians should facilitate over the tracheal area breath sounds during inspiration to correct a cuff leak. The cuff is reinflated and the cuff pressure is a minimum technique is used to cuff leak and tracheal air sounds should be present at peak inspiration under normal conditions. More detailed information on checking the circuit. Small ETs, such as those used with neonates, do not have cuffs for a minimum amount of air to lead to migration of the ET to the upper airway of vocal cords is another possible cause of a leak associated with the ET. Also, can the junctions in the patient circuit where sections exist. Sections water is an agent in line. There's temperature probes, inline mediators, proximal airway pressure lines, capnographs, CO2, sensors, and unseated or leaking. Another less common source of leaks is a pleural drainage system. This issue for pleural leaks sometimes can be accomplished by increasing volume delivery to the patient. The amount of air locating the pleural drainage system can be determined by comparing the inspiratory volume. Are typically performed is prepared for patient use, but these checks can also be performed while the equipment is in use. For example, chart. Newer ICU ventilators can automatically perform the patient ventilator circuit test. A leak check can also be performed leak without during patient ventilation. Ventilated manually, the clinician changes ventilator mode to volume and sets one to 100. The flow liters per minute. The inspiratory pause is 2 seconds to maximum. Curve is occluded with sterile gauze and the ventilator is cycled manually. The circuit pressure that develops during inspiration should plateau and hold at the level, falling no more of water during falls. More than this, a significant leak is present and must be corrected. If the leak cannot be corrected quickly and easily, a change of equipment may be necessary. Inadequate oxygenation. A condition of inadequate oxygenation is signaled by activation of low CO2 alarm. Patients typically demonstrate tachycardia, although bradycardia may also occur. That's hypoxemia. 4-1 for the signs and symptoms of hypoxia. Continuous blood gas exit is required to confirm the presence of hypoxia. It is important to recognize that worsening hypoxemia can be an ominous sign of deteriorating lung function. Next section, inadequate ventilator support. Ventilator settings can cause an increase and ultimately lead to patient respiratory security. Respiratory acidosis and hypoxemia may also be seen in cases where the patient experiences a chapter 17 contains more information on effects of increased WB. Sensitivity level can be improperly set. Is a sensitivity is set to low. Lack of ventilator to inpatient and respiratory effects may be the result of incorrect security settings, low flow settings, or a poorly responsive and valve. The trigger sensitivity may also be altered when a nebulizer is being used by an external, which can blunt the machine's ability to sense a patient's breath. Other causes are water in the inspiratory line and the presence of auto can be corrected easily by simply by increasing or decreasing the sensitivity setting. If this does not solve the problem, the other causes must address inadequate flow setting. A low flow can be corrected by increasing the flow setting patterns such as using its 7 gram rather than looking inspiratory or doing speed indicates active inspiration flow. Figure 18-3. Ventilation also may be effective means of providing adequate flow to the patient. From BCCMV, with a volume target to achieve pressure regulated volume control, the flow pattern sometimes relieves distress. Patient ventilator is secret. In addition to an appropriate setting, other types of patient ventilator can occur. See Chapter 17. Increased ventilator drive or the need for selection as patient ventilator is indicated. The airway pressure P fluctuates dramatically. The respiratory therapist must determine the problem. Or the patient may have a breath. Patients with COPD with airway obstruction say low level of problems. You like 7-1 and figure 7-1. This breathing may also be seen with COPD when pressure support ventilation is used. COPD patients often show inspirations and active lung exertion. Actively with days of PSD, not through necessary cycles. The values and inspirations on the pressure supported graph. Rise in the scale at the end of breath. It can be avoided by having these patients use a ventilation flow cycling characteristics. During PSV, another problem may occur in patients and the pressure are set too low. Thus, patients Transition to isolation may be effective. Let me check. Testing. Are we still broadcasting? We are. One transition various times later. Fox 18. Trigger is sensitive. Confirm that the sensitivity level or can we figure three to open the exhalation valve. If all efforts have been medication, ventilate a sleeping valve, and a solution cannot be found, medication may be necessary. Severe issues, either alone or with neuromuscular blocking agents may be the most effective method to resolve severe distress patients. Clinician must make a systemic attempt to find the cause of the problem and correct it before recommending medication. Situation. Ventilators and monitoring can have a number of alarms to notify the practitioner of changes in the patient's status. Appropriate use of these alarms is essential for patient safety. Blood pressure alarm. As already discussed, low pressure alarms are most often activated by leads. Box 8 to 7. The low pressure alarm activates the clinician first to check to ensure the patient is being ventilated. If the alarm occurs because the patient is inadvertently on the ventilator, the patient is simply be reconnected. Otherwise, the patient may need to be ventilated immediately until the source of the leak is identified. Once the problem has been identified, the clinician should reset the alarm that is dead about 5 to 10 centimeters H2O below uh, resolution of various types of ventilator symptoms. Confirm that the sensitivity level has been set appropriately, that air trapping for auto peak is not present, and that the patient is not agitated. Ensure the flow is inadequate and the flow delivery is PSV ensures the patient is not exhaling actively. The pressure controlled exhalation, make sure the duration mode is sequence. First, when more than one type of breath is delivered, such as the SIMV, another mode may be include suspension speed and epilepticus, epileptic trauma. Setting that is too low. Make sure people set at the appropriate level. Closed loop ventilation is super. Closed loop mode may not be performing as needed for a particular patient. Make sure current settings are appropriate. Consider selecting another mode. Okay, pressure alarms are incorporated into all current IC ventilators. High pressure limits at about 10 centimeters H2 above bed, leading to activation of high pressure alarms can be categorized as airway problems. Change with the patient's lung characteristics, conditions, and problems related to the patient's audible and visible high pressure levels are typically patient coughs or some ET. Arms also will become activated when secretion builds up in the patient's airway. Usually is self and does not require use of a bite block or pharyngeal air wrap for the responsive patients from body and ET. Some commercially available ET holders have built-in bite blocks, and unresponsive patients can be instructed not to bite on ET simultaneously. Copies can be removed by suction that adversely affect a patient's lung characteristics, airway resistance, raw or decreased lung compliance, C1, or spontaneous breathing effort also can trigger high pressure alarms. Examples of conditions that are bronchospasm, conditions most often seen that are associated with C1 include ARDS, pneumonia, pneumothorax, and abdominal space dissension and asthma. Identifying raw and C2 changes can be identified by listening to breath sounds and evaluating changes in the pit level. Table 18.1 by interpreting radiographics case studies 18-2 and 18-3 and figure 18-4. Okay. A high pressure alarm may also be triggered when a patient actively breathes out of synchrony with the ventilator. Hip rises if the patient actively exhales while the ventilator is in the respiratory phase can activate the high pressure alarm. Later setting patient's condition that results in air trapping in the lungs. For example, ROP also causes the PIP to rise in addition, PIP may be elevated if problems arise in the patient's circuit. Water from condensation can lead to oscillations in the gas flow through the circuit and subsequent. Water is a circuit. In the circuit can lead to increased PIP and sometimes activation of a high pressure alarm. Heats in the surface also can lead to PIP and alarm activation. Several possible problems should be considered are rising. For example, nebulizer medication, respiratory filter and exhalation valve, gas flow through the filter valve. Consequently, the exhaust valve may be unable to open completely. Sensors should be recalibrated to correct the problem. HMEs also can accumulate excessive secretion and increase flow resistance. The expiratory flow and expiratory volume return to the baseline in figure 18.3. This is a graphic example of increased expiratory resistance. Note A partly distracted HME can also produce the toughness likely feature. The center of the high-pressure alarm that patient safety must always be priority. Key point 18.4. The clinicians must ensure that patient airway and being oxygenated. Polarizes physician as first. 18.4. If a problem arises, the clinician's first priority the patient safety. Okay. Some figures. Figure 18 reporting delivery of mandatory drug constant flow volume control continuous mandatory ventilation. So for features trigger threshold in the normal breath is patient triggered with the pressure curve is concave because the patient's active tends to inhale. Common causes of blood pressure low. Patient disconnection, circuit leaks. And 7. Common causes of blood pressure low. Patient disconnection, circuit leaks, which is disconnection of respiratory or expiratory ventilatory circuit, humidifiers, filters, water traps, inline meter dose inhalers, inline nebulizers, proximal pressure monitors, flow monitor devices, inline closed suction vessels, temperatures monitors, cracked or leaking valves, unseated valves, improperly connected valves, use of minimum leak technique, endotracheal tube, ET cup inflation, pilot balloon, cup pilot balloon, rupture of the ET cup, migration of ET into upper airway above the vocal cords. 18A. High pressure airway, coughing, secretion of mucus in the airway, patient biting the ET or intubation. As the ET inside the mouth toward the back of the throat of the ET on the trachea arena. Of the ET to the ready stream and brainstem bronchus of the ET to the end of the tube. Conditions related to the lungs. Airway resistance. Increased secretion, control for edema, bronchospasm. Decreased compliance, pneumothorax, pleural effusions. Changes in the ventilator circuit. Accumulations of water can condensate in the patient's circuit. In the inspiratory circuit, inspiratory expiratory valves. Next page. Chapter 2. Right, patterns of alteration in thoracic relationship. So this is the table. Low low deep sea cup alarms activate when the airway pressure falls below the desired baseline DMP or CPAP. This may occur when the ventilator could not compensate for another possible cause of the low pressure lung is the activated expiration by the patient. Patient can cause the pressure to drop below their alarm setting. The machine sensitivity may not be responsive enough to the patient's effort, or the ventilator demand valve may not open quickly enough in response to flow demand. Respiratory gas flow at too low is not responsive to patient's respiratory effort. The peak level drops, which may activate the alarm. Activating the alarm may indicate patient apnea or patient dyspnea. Inadequate machine sensitivity to reset apnea. An apnea alarm may be accompanied by low pressure to alarm. Some have apnea periods of silence in one alarm. Some ventilators have a preset apnea period of 40 seconds, whereas others allow that ventilators are defined. The alarm sounds most obvious cause after making sure the patient is being ventilated. The clinician should also check the disconnection analysis. I don't think I don't think she's doing right now. But technically, okay. Okay. Uh, 63. Here's top part. I'll start there again. And so you started seeing design to spontaneous and enter rest. That's when mapping alarm sounds most obvious cause is patient apnea. After making sure the patient is being ventilated, finishing the breathing rate and the machine check for possible leaks or patient disconnection. Cases where RVP is presented is rendered more difficult, resulting in unprotected effort. Mode, using PSV or CPAP, was validated to reduce interpret this. Some ventilators provide a backup mode of ventilation when is activated. Backup modes generally provide a level of ventilation for the patient until the operator can respond to the alarm and correct the problem. Some ventilators go into the backup mode once the patient is detected. Next section, low source gas pressure or power input. Gas around activates into gas source, falls for the high pressure line in the gas source. they must ensure that the compressor is operating. Note, some ventilators such as the Bear 1000 or feature devices support CVD help, which must be turned on. Current ICU ventilators such as the Fulton Bennett be turned on the compressor when there is a pressure in the patient's ventilator circuit. Further, the air and oxygen lines are connected to an active gas supply, such as a wall outlet. Processor control ventilators require electrical power source. Ways the clinicians first confirm that is connected to an active electrical outlet and has not been unplugged. Is the leg working and the unit faucet fails to start? Use of circuit breaker may need to be replaced with a step. These ventilators have a reset button which, in the event then overall power outage. The ventilator should be plugged into electrical outlet. These outlets are connected to emergency generator power supply. Many current ICU ventilators have backup battery power solutions operating the unit for 30 minutes to 4 hours depending on the ventilator and battery. What? Oh Lord. Ventilator inoperative alarm and technical alarm code message. Microprocessor control ventilators inoperative alarm message activities activates malfunctions affected by ventilators subdusting system. When occurs, it is first turned off. Returning the machine off and then back on to it may be necessary to replace the ventilator. Operator settings incompatible with machine parameters. Message or alarm or both is triggered if the operator is setting that is outside the range. With incompatible, like for example, if clinician tries to set a V milliliters, the VT range for the ventilator is 200 to 2,000 milliliters. That the setting cannot be selected. Functioning available setting can occur. We use volume control ventilation. Respiratory gas flow that cannot be set repeatedly except in the time based on the set. The machine produces an air message asking operator to correct the flow and reduce the VT. Inspiratory to expiratory rate indicator of the line. Most current ICU ventilators do not last expiratory 9 and 1. Unless the operator specifically wants this. This generally requires sensor control or touch function that looks like operator or system. An inverse ratio alarm may activate if a change occurs in the patient lung characteristics, i.e. increased lung decrease in one, resulting in lower inspiration character did not have because of the emotional driven too many changes other than possibly useful for saying that it's too low for these higher and also changes like it. For example, changes in a constant flow to suddenly ramp with when a volume is powerful into the T1 and I say control ventilation and depending on the setup may activate the IE other lines. Maybe on the IC that's high P alarms, low and high V alarms, low and high V, a high alarm, and low and high alarms. IP CPAP alarms often are activated by the same problems that we low VT1 alarms. Low VT usually activate in situations that cause low pressure alarms or when the patient's spontaneous decrease for more reasons. Sensors disconnection, leaks, or malfunctions can often be the high F and high VT alarm in the patient's VT or the ventilator sensitive to patient's effort. VT alarms may also be activated if a necessary for external gas source is in line with the main circuit. These problems may lead to calibration, contamination, low sensors. T9 involves 85% several chemical situations that can be associated with activation. It's important that the clinician be familiar with and their various alarm systems. Then we have table of alterations of thoracic pressure volume relationships. And now, 1 hour case study, and plateau pressures 10, 10, 10, 30, 40, 20, 40, 60, 60, 60, 20, statistics, 36, 30, 18, inspired pressure, plateau pressure, 2 plateau, and volume control PC ventilation. Ventilation support, PCCM, air pressure law, several equations, window. Nursing happened in the 72 hours earlier following an vehicle crash and chest trauma without pneumothorax. Previously seen events with the stage test. Cases have severe hypoxia, epigastric, respiratory therapy, bilateral, no bilateral freckles, particularly in the lung bases. No withdrawal. Associated graph shows bilateral pause increase in hip and P plateau. Diagnosis for patient based on physical findings. Case study 18B. Evaluating hip and volume pressure control ventilation. Give asthma has been receiving pressure ventilation in the PCMB mode after open heart surgery. Occasionally, the high pressure alarm has been heard in the triac force of this. The low V1 VT alarm was also activated several times. Routine monitoring. 9, 9.75, hit CM 5, and F breath per minute is 8. Time 10, volume is 0.68 liters. Again, the hip is 25 centimeters of H2O, and then the F breath per minute, 11 p.m. after 11, I guess. 0.6 hit is 25 centimeters of H2O again, and then F breaths per minute is 11. What shows the flow volume lead measured on the patient? 11 hours. Breath sounds reveal bilateral scattered rare wheezes. The change in the volume variable. What therapy would you recommend? Figure 18.4. Flow volume is below the x-axis and the acceleration occurs for properly. Arrow A, critical. Arrow B indicates increased expiratory resistance. When you use the trajectory flow. 5 represents the predicted expiratory flow lead in this patient. Okay. Use of graphics to identify ventilator properties. Ventilator graphic displays can provide valuable information that clinicians can use to evaluate the integrity of the patient's ventilator system. Have you considered your ventilator graphics? Chapter 9. Examples of ventilator associated pump test. The following takes us to page 364. Oh my god. Okay. If an alarm activates for abnormal waveform, waveform appears, the Assess the patient's appearance to evaluate for distress. The patient is receiving adequate ventilation and oxygenation. See if necessary, and if the patient is suffering severe distress, disconnect the patient from the ventilator and manually ventilate. Uh, uh, Adding P if needed and increase the F102. Reassess the patient. 5. Check the activator alarm and make sure alarm parameters have been set. Once the cause of the problem has been determined, resolve it. 7. If the problem cannot be resolved, change the ventilator or call for help. Alarm situation. Blood pressure alarm. Check the patient's history action. 1. Fluids in the patient's circuit related to the artificial airway and including chest. With proximal pressure line is significant and poor low pressure line may be accompanied by normal ventilation. Let's have a volume alarm. High pressure alarm. The patient is coughing, whether it's the airway or the patient is being tracheal ET. Displacement of ET. Also check the position. The ensure that the ET is not inserted too far into the trachea. Flow has increased. The C or the C1 has decreased. 4. Ensure the main social lines are not obstructed. Check that the patient is breathing safe ventilators. Air trapping or auto breathers develop. 7. Ensure the respiratory filters are functioning properly. Other than expiratory or PVC cap alarms. 1. Check to determine whether the low peak alarm is set below the 5 peak level. Whether the patient is actively below baseline. After 8 weeks pregnant. 4. Confirm that the patient has not become disconnected from the ventilator. 3. 5. Ensure that the proximal airway pressure line is not obstructed. Apnea. The patient is apnea. Determine whether the patient is apnea. Check for leaks. Check the sensitivity setting to be sure that the ventilator can detect patient effort. Interval and volume setting when appropriate. Gas, pressure, or power input loss. 30, 50. Air conditioner. 2. Measures the ventilator. 3. Check ventilator's electrical power supply, whether it is plugged into the electrical outlets, the emergency backup system. 4. Check the line fuse or circuit breakers. Reset button. 3. Replace the ventilator. Ventilator in outdated alarm or technical error message. Then the turn malfunction message is present and the ventilator is turned on. Turning the ventilator on the alarm should be right place. Operator saying anything to help. Error message usually indicates that you must be flow is not high enough. one would be acceptable to keep the IE ratio 1 and 1. And two approximate so to start the IE 1 should indicate an IE ratio greater than 1 and 1. IE ratio is a ratio for your if normal or circular causes. Or decrease has resulted in lower flow to the cause. If the flow surface to delivery or change possible by capitalized. Causes possible those perhaps flow synthesis. Low OVT, low and low FLR. So this shows a low pressure with the spontaneous ventilation. Has a huge percentage. I'm going to set appropriately for disconnection running off. CIV or checking sheet sensitivities are the sensitivity level for audio cause of decreased patient. Alarms have been set in external levies. We set the alarm until the treatment alarm to the appropriate facility. Sensors for calibration, contamination, and nothing. It should build in alarm oxygen for its function properly. And encourage you to be or graph is verify patient stability and adequacy of ventilation. Is patient increase? If yes, check cause of increase in determine change. So I'll trigger. So now here, setting. Two checking setting. If the no, then we go to is an external nebulizer in use? Yes or no? Again, so just consider treatment is completed. If it's no, then it's the flow and it's not functioning. If that's yes, percent. The two is that it's not. Should is necessary. set to the yes, just as select operator manual and character from manufacturer. And this again is phase 5, 18-5, pushing activate a lot. A title volume. B, C, or rate. One, B, inflation. B, low pressure, and now part has pressure, low P, low PT, next graph, verification, stability, and uh, inflation. As the patient is connected with yes, no, circuit, yes, when the circuit, if no, is there a cuff? Take the cuff and check the pressure's pressure. So, is there chest? Yes, contact position. There cuffing. If yes, reinforce the cuff as the recur. This is the question two. Is pilot this a patient? Uh, yes, the proximal yes, so will not function. Yes, and recalibrate it to put the sensor line and recheck it. So function and replace sensor if necessary. The full sensor malfunctioning. Your alarm set inappropriately. Yes, reset the alarm. Check the operator manual and or the training specialist. Okay, then take a small break for a moment. We're still connected. Testing, testing, testing. Testing, testing. Testing, testing. Yay. We're still live. Okay. Okay, okay. Now we have Hickory high. Continue. Sure or high. Avalon. Tracheal tube. IT inspiratory time. Time. Airway. C. Verify patient. E. Artificial airway can be cleared. Yes. Change the artificial airway. The patient coughing. Yes. Suction the patient and or patient coughing. No. Patients in the airway. Yes. The patient. No. Is the patient circuit yes been drained? Condensate three ventilator circuit board lines for kids. Circuit obstructed. Patient belong being the patient by yes inserted by block. Two is the position of the way incorrect. Yes, the position or no. Is the wrong door? Yes, patient problem. One secretions, two bronchospasms, three pneumonia. angina, 6 pneumothorax, 7 pleural effusions. No, asynchronously. Yeah, cardiac sensitivity, 3 check ventilator parameters, 4 check mode of ventilation, and 5 consider sedation. Is auto-P present? For increased raw, e.g. suction bronchodilator treatment or increased ET size is appropriate. The flow to increase TE. 3 decrease the VE. Is auto-P present? No. Involve malfunction. Fix or replace the valve. No. Pressure too high. The pressure. No.